When a patient presents with similar symptoms, like in this case, we typically start with an upper endoscopy, and in this case, an upper endoscopy revealed a primary tumor in the stomach. At that point, staging scans would be done with CAT scans, chest, abdomen, and pelvis. And if there's no evidence of disease, then an upper endoscopy with ultrasound would be performed to get a better sense of the local stage with the T stage and N stage. And if there's still evidence of locally advanced disease without evidence of metastatic disease, consideration of a PET scan and then a diagnostic laparoscopy would be performed, particularly in the setting of a T3 or higher or a node-positive cancer. This is because despite having a normal CAT scan, a normal PET scan, and an endoscopic ultrasound that don't reveal any evidence that's definitive for metastatic disease, approximately 20 to 30% of these patients with a T3 or higher or a node-positive disease will have occult metastatic disease to the peritoneum. So a diagnostic laparoscopy is performed in that setting to identify these patients. If it is found to be there either macroscopically that the surgeon can see or microscopically through cytology washings, then that by definition is now stage 4 disease, and curative intent surgery is typically not recommended. And that patient will be treated like a stage 4 patient with palliative intent. If, on the other hand, there is no evidence of metastatic disease, even with diagnostic laparoscopy, then a patient will go down a different treatment path in terms of perioperative therapy and surgery with curative intent. When patients are diagnosed, particularly with stage 4 disease and with gastric cancer, we run, at minimum, HER2 testing, which is done by immunohistochemistry as a first pass. If it's 3+, then it's considered positive. If it's 0 or 1+, it's considered negative. And if it's 2+, it's considered equivocal, and reflex FISH testing is performed. And if the ratio of the HER2 probe versus the control probe is greater than 2, then that's considered positive. This is because, of course, if you're HER2 positive, then you would get chemotherapy plus the HER2 targeted agent trastuzumab. So, in this case, the patient was HER2 negative and appropriately did not get HER2-directed therapy. We also, at my center, perform a gamut of other molecular tests, which include microsatellite instability testing by immunohistochemistry. We also perform PD-L1 testing by immunohistochemistry, and we perform next-generation sequencing panel testing on the tumor, which also includes tumor mutation burden and also MSI-high testing through a different assay. This is taken into account in terms of planning the patient's overall course of care through first line, through later lines of therapy.